and with it, you will find HER2 amplification. How do we know that there is CEP17 amplification or polysemy? The signals that, remember when we use FISH, we use green and red, so the green signals would be increased. Typically, we see 2 green signals per nucleus or less. If you see the definition, the more sort of like adopted threshold is if you see 3 or more signals per nucleus, then there is a potential that this tumor has polysemy 17. The prevalence again varies from 3 to 46%, and that just reflects that we do not have a standardized method to measure polysemy 17. So to simplify the concept, here's an example. Figure A is a nucleus that has the typical 2 copies of chromosome 17, and near the centromere you can find a green signal, 1 green signal, you can find 2, that's still normal, in each chromosome, and a red signal for HER2. So this is non-amplified disomic, meaning we have 2 copies, the normal 2 copies of chromosome 17. Figure B, you have 2 copies, so it's disomic. However, you find many red signals, so that means there is HER2 amplification in a disomic nucleus. Figure C, you see, instead of the usual 2 strands of chromosome 17, you see 3. So this is an example of polysemy chromosome 17 with the entire chromosome, an extra copy of the entire chromosome. However, if you look at each chromosome, it has only 1 signal of each. So if let's say we calculate the HER2 ratio in part C, in figure C, it will come back non-amplified. Correct? However, look at D here. We have 2 chromosome 17, which means it's disomic. But one of them shows 3 signals, 3 green signals, and 3 red signals. So obviously, this chromosome has amplification of both HER2 and CEP17. But if you calculate the ratio, how many greens do we have here? 3, right? How many reds? We have 3. So the ratio will come back non-amplified. But we actually have amplification of the HER2. We have 1 chromosome with 3 copies of HER2, that's amplified. Also, we see the amplification of the CEP17, the green dots. So these are the patients that we can potentially miss amplification in. We'll get a normal ratio, a ratio less than 2, but we are going to miss the true amplification here. So this is the problem with polysemy 17, that these patients are going to be missed if we only rely on the HER2 to CEP ratio. There are other clinical pathologic features and issues related to polysemy 17. Of course, when you have an entire chromosome, an additional copy of an entire chromosome, you're increasing the gene dosage even if you do not have true amplification. And usually these patients test 2+ or equivocal. There are other genes on chromosome 17 that are oncogenic, for example, BRCA1, P53. So that means patients with polysemy 17 may have worse prognosis because the extra copies of all these oncogenic genes. Some studies, a study that came out in 2014, showed that elevated CEP17, which is a form of polysemy, may confer a more aggressive phenotype and unfavorable clinical pathologic variables, even if you do not see evidence by the test of HER2 amplification. And also, the data suggests that trastuzumab or anti-HER2 treatment may be efficacious in polysomic HER2 amplified tumors. So, meaning that we have to detect polysemy 17 in the FISH test to be able to decide whether to give these patients treatment or not. So for now, the guidelines suggest that when we do the FISH test, whether it's the initial test or a reflex FISH test, and we see evidence of elevated CEP17, meaning that we see numerous green signals in the cells, we have to look at the HER2 copy number, regardless of the ratio. If you see 6 or more copy numbers, 6 or more red signals per nucleus, then that's a HER2 positive tumor, regardless of the ratio. If you see less than 4, that's a HER2 negative tumor. Between 4 and 6, that's sort of like tricky. You might have to do another immunohistochemical test if you didn't do it in the beginning, or repeat it. If you get a 3+, then regardless of the copy number, you call it a HER2 positive tumor. If you get a 0 or 1+, that's a HER2 negative tumor. If you get a 2+ again, in the clinical setting, you might want to repeat the test on a different tissue block, and if the results still come back equivocal, then consider it HER2 negative. Of course, in the research setting, you can use other markers for chromosome 17 other than CDP17, like SMS or RARA. Or you can do molecular karyotyping, which will sort of like a higher resolution genetic karyotyping where you see locus by locus in each chromosome. So that's the pitfalls in HER2 testing. Yesterday there was a very nice lecture that went over in detail the KI67 guidelines and issues. I'm not going to go over that in detail. I just wanted to talk about this interesting experiment where they selected 6 reference labs in the United States, and they sent them a pre-stained set of tumors stained with K67. And they asked them, okay, go ahead, take the sets, score them the way you do, and tell us your results. So the interesting thing is that, and in each lab, multiple pathologists read the slides. Interestingly, within the same lab, there was good concordance between the pathologists. But between different labs, there was moderate to unacceptable poor concordance. So that's why we still do not use P67 in the United States routinely to test for in tumors, in breast cancer. And still the ASCO does not endorse using it routinely in the clinical setting. Androgen receptor. Androgen receptor is typically expressed in apocrine carcinomas. It's a nuclear stain, and it has been shown to be associated with improved disease-free survival and overall survival. The significance of androgen receptor expression is that it offers potential for therapy with anti-androgen drugs in triple-negative breast cancer. Apocrine carcinoma is one of the typical triple-negative breast cancers. Another biomarker that is expressed in up to or amplified in up to 92% of triple-negative breast cancers is EGFR. 26% of tumors that express EGFR also have concomitant PI3K and BRAF mutations. The clinical significance of testing for EGFR in triple-negative breast cancers is that we do have some EGFR-targeted therapies combined with PI3K and BRAF inhibitors that we can offer to these patients. All right, so we have gone through over the immunohistochemical tools that we have available so far in breast cancer, but still there are limitations to these tools. So maybe we need something that can incorporate or encompass all these markers in one assay and give us just a number to tell us what to do, to tell the clinicians what to do. And that's what happened when, it wasn't until 2000 when Peru and his group performed microarray-based gene expression profiling of breast carcinomas. And that was a revolutionary study. I think they did it on like around 700 samples. And they discovered that breast carcinoma is a very complex tumor. Generally, there are usually 4 or 5 subtypes that are discussed. The ones that are usually there are luminal breast cancer, and basically they are called luminal because they express the luminal genes that are expressed in normal luminal breast cells. These are divided into luminal A and luminal B. Luminal A express more of these luminal genes than luminal B. Both luminal A and B are usually hormone receptor positive. There is the HER2 positive or HER2 enriched, and usually they are hormone receptor negative. There is the basal-like, and there is this fairly newer category called cloud and low, and I'm going to go over each one of them in a little bit more detail. There used to be the breast-like entity, but now they're sort of like discarding it because they think it was because of contamination by normal breast tissue. Alright, so luminal A tumors, they are typically ER/PR positive, HER2 negative, with low Ki67. Of course, there is an exception for every rule, but this is the majority of luminal A tumors. These tumors have good prognosis, they are endocrine sensitive, and they are chemo-resistant. The common histologic types that we can sort of like, if we look under the microscope, we can predict that this is going to be a luminal A, low-grade carcinomas ductal, classic globular, tubular carcinomas, mucinous, and cribriform. Here's an example of a low-grade ductal tumor, invasive ductal adenocarcinoma, with frequent lumen formation, tubule formation. Here's an example of cribriform invasive carcinoma. It's very rare, but it carries excellent prognosis. And here's an example of mucinous, with basically you see clusters of tumor cells floating in mucin pools. Now, the luminal B is again ER/PR positive. However, unlike luminal A, luminal B carcinomas can be HER2 positive and they can have high Ki67. These tumors have less favorable prognosis. Actually, there's a study that found out that luminal B, after 10 years of follow-up, the survival of patients with luminal B carcinomas overlaps with that with basal carcinomas, which means that these patients, after 10 years, they will have the same bad prognosis of the majority of basal-type carcinomas. That means they need more targeted therapy, they need prolonged endocrine therapy, more than the typical 5 years. These are all questions that clinical trials are still trying to figure out the answers for. Typically, these patients will receive, in addition to the hormone treatment, they will receive HER2 targeted therapy and chemotherapy. However, unfortunately, they can be chemo-resistant, however, they respond more than luminal A. The typical histologic types that are luminal B are grade 2 or 3 ductal and micropapillary carcinomas. The third group is the HER2 positive or HER2 enriched. These tumors are typically ER/PR negative and HER2 positive from their name. They benefit from HER2 targeted therapy with or without dapatinib, which is a tyrosine kinase inhibitor that enhances the effect of trastuzumab. They also typically receive anthracycline-based chemotherapy. The common histologic types include grade 2 or 3 ductal carcinomas, apocrine carcinoma, micropapillary, and pleomorphic globular. And here's an example of pleomorphic globular carcinoma. So typical or classic globular carcinoma usually has a very low-grade nuclei. However, this pleomorphic carcinoma has more pleomorphic nuclei, hyperchromatic, high NC ratio, and you can see here the typical intracytoplasmic mucin with a signet-range cell appearance that you can see in globular carcinoma. This is an example of micropapillary carcinoma, and basically you see clusters of cells with a space or a clearing around them, giving it the micropapillary look. The fourth entity is the basal-like, and these tumors are typically, well, the majority are triple negative. In addition, they're called basal because they express basal cytokeratins. They are EGFR positive, c-KIT positive, and they have high Ki67. The majority of these tumors have poor prognosis, and we do not have much to offer them but chemotherapy. The typical common histologic types include grade 3 invasive ductal carcinoma, medullary carcinoma, metaplastic carcinoma, and adenoid cystic carcinoma. And here is an example of a poorly differentiated Nottingham grade 3 carcinoma where you see sheets, basically without any differentiation, sheets of cells with high nuclear to cytoplasmic ratio risk mitotic activity. Here's an example of metaplastic carcinoma spindle cell type, where the cells start to have spindle nuclei and basically acquire a sarcomatoid look. And here's an example of another example of metaplastic carcinoma, the squamous carcinoma. We see squamous cells, high nuclear grade risk mitotic activity, and this is an example of mesenchymal type of metaplastic carcinoma, where you can see the tumor starts to acquire heterologous elements, in this case cartilaginous differentiation in the form of a malignant chondrosarcoma. Now the last entity is the Claudin low, which is the relatively newer entity. So Claudin basically is, Claudins are proteins that are involved in the intercellular tight junctions. They regulate the tubules between cells and the trafficking of nuclei between the cells. If they are lost, the cells become discohesive and undergo this phenomenon called increased epithelial to mesenchymal transition, or EMT. So basically EMT is a phenomenon by which these cells start losing their epithelial gene expression and acquiring mesenchymal gene expression. So basically they acquire sarcomatous-like or mesenchymal-like gene expression criteria that enables them to first, number one, be more invasive locally, and number two, give them more propensity to metastasize. So basically, they behave aggressively. These represent 30% of, 30% of them are not triple negative. In fact, they can express biomarkers, and we do not have any specific treatment for them. They are offered anthracycline or taxane chemotherapy. The common histologic types include grade 3 invasive ductal carcinoma, also medullary carcinomas, and metaplastic carcinomas can be Claudin low. Here's an example of medullary carcinoma. Typically, medullary carcinomas have pushing edges, pushing invasive edges, and you can see sprinkling of lymphocytes and plasma cells, inflammatory cells, in between syncytial sheets of cells with high-grade nuclei, prominent nuclei, and risk mitotic activity. It has been shown in multiple studies that the intrinsic classification of breast cancer has its own prognostic value, independent of the tumor size, the lymph node status, and here's the survival curve that came out that was demonstrated in a paper that came out in 2011. The blue line represents luminal A, and the red and the mauve lines represents both the basal-like and the HER2 positive. And clearly you can see that the blue line, whether it's overall survival or disease-free survival, have the best prognosis reflected in the well-known luminal A good prognosis, and the basal type or HER2 have worse prognosis. This slide I put there just to emphasize that not all triple-negative breast cancers are basal-like, and not all basal-like are triple-negative. Actually, any tumor that belongs to any other intrinsic subtype can be triple-negative. But however, the majority of triple-negative tumors are basal-like. All right, so back to the assays that can incorporate all the biomarkers that we have, all the molecular technology that we have, and give us a score that can tell us, is this patient going to benefit from a specific type of treatment or not? So basically, these are predictive assays. They are used by clinicians, of course, especially in hormone receptor positive patients, to help them decide whether to add chemotherapy or not. The most commonly used assay in the United States is the Oncotype DX. So the Oncotype DX, basically, they use the gene expression of 21 genes using RT-PCR, and they can use we can give them formula-fixed, paraffin-embedded tissue, which is really easy. We don't have to give them fresh frozen tissue anymore. We just give them the fixed tissue. We select a representative block of the tumor and send it off. We have centralized labs, so not every lab does this. The Oncotype DX predicts the likelihood of distant recurrence in ER-positive, tamoxifen-treated, node-negative patients. So why is this important? This is important because if the patient is ER-positive and they don't express, for example, they are HER2 negative, some patients might benefit from chemotherapy. However, chemotherapy is not an easy decision to make, to give to the patient because of the enormous toxicity and enormous side effects. So in certain clinical scenarios with smaller tumors, lymph node negative, the clinicians need some help to help them decide whether to add chemotherapy or not. So Oncotype DX helps them in the form of giving them a score, which is called recurrence score or RS score. If the score is less than 18, well, this score, let me go over this first. So how do we come up with this score? We measure the gene expression level of the 21 genes. Most of them are estrogen and Ki67 or proliferation-related genes, and we put the values in a formula that comes up with a number. If the number is less than 18, that means that this patient has a low risk of recurrence, around 7%. If the recurrence score is 31 or more, that means the patient has high risk of recurrence, around 30%. If it's in between 18 to 30, that means there is an intermediate risk around 14%. And ER and Ki67 consistently have the most predictive power. This is a paper that came out in 2004 that shows the prognostic value of the Oncotype DX. This is the x-axis represents the recurrence-free survival, and the blue line here represents the patients with a low risk. They have the best survival compared to patients with high risk. The red dotted line here, they have worse survival. And not just a prognostic value, Oncotype DX has an additional predictive value. This study demonstrates that. So here's, let's look at this graph here, part D. So the x-axis represents the proportion that have disease-free survival. The blue line represents patients with high-risk recurrence score that receive tamoxifen and chemotherapy. The red dotted line represents patients with high risk that only receive tamoxifen without chemotherapy. And you can clearly see that the patients who received chemotherapy had a much better survival. So the recurrence score can help actually predict whether patients are going to respond to chemotherapy or not. The problem with the Oncotype DX, as we mentioned, there is the low-risk group, there is the high-risk group, and then there is the intermediate group. Most of the patients fall in the intermediate group, around 60%. So why is that a problem? It's a problem because the intermediate group, there are no studies that tell us that whether they're gonna have prolonged disease-free survival or not as like the low-risk group, and there are no studies that tell us whether they will definitely benefit from adding chemotherapy to the hormone treatment. So if you give the result back to the clinician and tell them, well, this is an intermediate risk score, well, basically that's useless to them. I mean, so what are we going to do now? Should we give the chemo or not? That didn't really answer the question. So this is the TAILOR-X trial, clinical trial that's ongoing in the United States right now, and they are studying the intermediate risk group. So basically, the patients that fall in the intermediate risk group are randomized to receive hormone treatment alone, and an arm would receive chemotherapy plus the hormone therapy. And then they will follow the patient and see the survival. The preliminary results show that most of the patients that fall in the intermediate risk group are actually, they do not need chemotherapy. But the final results are still to come. The second most commonly used molecular assay in the United States is the MammaPrint, which is a 70-gene microarray versus the 21 in the Oncotype DX. This assay gives only two results, either low or high. Remember, the Oncotype DX gives low, intermediate, and high. The only thing with the MammaPrint is it requires fresh tissue. Only recently they started performing it on fixed tissue, but this hasn't been widely validated yet. The FDA approves it, but it's not endorsed by ASCO or the National Cancer Network yet. It has a prognostic value for early distant recurrence for both ER positive and ER negative. Oncotype DX is mainly for ER positive, although they have started using it in ER negative patients as well. And the MammaPrint is currently being validated in the MIND-ACT trial. Other assays available, and I know that maybe the oncologists here use PAM50 more than Oncotype DX. But these are other assays available. Basically, the difference is that they use multiple different set of genes, different number of genes, but they all more or less have the same value. Well, the problem with these assays, they are nice, very nice, if they tell us the patient is a low risk or the patient is definitely a high risk, but if the patient falls in the intermediate risk group, they are not that helpful. Also, there is discordance between different molecular signature assays. For example, 50% of patients that fall in the intermediate risk by Oncotype DX are reclassified as low risk by PAM50. On the other hand, more than 30% of MammaPrint high-risk patients are reclassified as low risk by Oncotype DX. So you can see that these tests, because these examine different set of genes, they give different results. And so the question is, which test should we use? We do not know. It's just the test that you feel good with. And the other issue with the molecular assays is that there are no molecular markers that reflect the clinical variables. Like, there's no molecular markers that can reflect the lymph node status or the size of the tumor. So these molecular assays do not incorporate clinical variables, and the clinician has to put them together. They actually use a website called Adjuvant Online, where they put the clinical variables and they also come up with a risk score. And then they use the Adjuvant Online together with a molecular assay and try to make up their mind. All right, so this is my last slide, and it has some science fiction in it. So basically, what are we at now? It's not a perfect world for breast cancer patients, especially those with advanced disease. Unfortunately, most of the patients with advanced disease are triple negative. They're young patients in their 30s or even in their 20s, and we do not really have much to offer them other than chemotherapy with all the toxic side effects. However, there is hope. The new technology, the next generation sequencing, might help identify new mutations specific for each tumor that we can target in addition to the chemotherapy. Or we can come up with assays that can encompass both the molecular genes and the clinical variables. All this through new high-throughput technology platforms like next-generation sequencing. But of course, this is still in the research setting. Another interesting thing that the researchers are working on right now, and they are trying to validate it in clinical trials, is the homologous recombination deficiency score. So basically, homologous recombination is a mechanism that the cell uses to repair DNA damage. Every day, every minute, there is DNA damage. Homologous recombination is what saves the cell from accumulation of this DNA damage and development of mutations that result in carcinoma.